Dear Pure Urology viewers, good evening one and all. I apologize for few minutes delay as I was in surgery. Today talk is en-bloc resection of bladder tumor. As you all know, the enucleation of prostate is so common now across the world. Even with new laser, thulium fiber laser also with 60 watts, enucleation of prostate is possible, especially with coagulative properties of TFL, absolutely no bleeding. Similarly, bladder tumors, as you all know, the getting of the pathology of the muscularis propria, lamina propria properly without any artifact of cautery is very important. Even I do en-bloc resection of bladder tumor, but today our speaker is world-renowned surgeon who is a crucial person in inventing thulium fiber laser in Russia, that is Professor Dmitry Enikeev. So I will introduce Professor today and then hand over the program to him. I thank once again, this is the second time Professor Dmitry is coming into Pure Urology, which adds a lot of value to the Facebook group. In this en-bloc resection of bladder tumor, Professor is from Russia. He is Professor of Urology, Vienna Medical University, Rabin Medical Center, Sechenov University. Dmitry Enikeev holds the position of Professor Urology in Tel Aviv University and Vienna Medical University. Professor Enikeev's fields of expertise include laser surgery, endourology, and minimally invasive treatment for prostate cancer. He co-developed the first thulium fiber laser, which became a prototype for a multitude of modern-day devices. Developed a technique for TFL en-bloc resection for non-muscle invasive bladder tumor, which award-winning video at AUA 2018 and third prize at EAU 2020. Professor Enikeev is a member of the available group of EAU section of Uro Technology. He authored over 240 articles and is an editorial board member of World Journal of Urology and Current Opinion in Urology. Reviewer for World Journal of Urology, British Journal of Urology, Laser in Surgery and Medicine, Translational Journal of Urology, AJU, BMC Urology, Andrologia, Research and Reports in Urology, the Lancet. That's really appreciable academic track record. I really appreciate Professor for coming back to this forum. Sorry for the delay, 5 minutes, and thank you. Over to you.
Thank you very much, dear colleagues, dear friends. It's my pleasure to accept the invitation and share some thoughts with my colleagues from India and all over the world. And today I was asked to give a presentation on rather hot and interesting topic. I was asked, and I would like to share some light on en-bloc resection for bladder tumors, and with focus on large bladder tumors, more than 3 centimeters. So let's start.
Yes, sir. Yeah, I am able to see your presentation. Very clear.
Yes, so you see my slides.
Yes.
So first of all, if we talk about bladder cancer, so according to World Health Organization, bladder cancer is among top 11 most frequent cancers in the world, and 75% of all bladder cancer is non-muscle invasive. So it's very interesting to see the changes in the European guidelines over the last years. So until 2016, standard transurethral resection was the only one option for non-surgical option for non-muscle invasive bladder cancer. In 2017, European Association kept this recommendation but added en-bloc as a possible option. And since 2018, en-bloc joined standard resection as a first-line treatment. So what is it, en-bloc? It's very important. It translates from French into all at once. It includes the tumor itself with surrounding mucosa with 5 to 10 millimeter margin. It's important. And muscle layer. So what was the reason for such changes in the guidelines. So we know that if we resect tumor completely, so we need to, without muscle, we have to repeat the surgery. And there were several reasons for that. So first of all, if we miss muscle invasive bladder cancer, it will quickly progress and increase cancer specific mortality. Another reason, if non-muscle invasive bladder cancer was resected incompletely, there will be a relapse. And it was proven in a large multi-center study, which was published in Urologic Oncology by Sharak Sharat and Paolo Gintero. So data of more than 300 patients were analyzed and main relapse predictors were described. And among them, carcinoma in situ, diffuser absence on pathology, and standard transurethral resection instead of en-bloc. So this highlights the importance of en-bloc as a novel modality for non-muscle invasive bladder cancer. So there was a very interesting study published more than 5 years ago in Journal of Endourology of over 200 endourologists polled. More than a third answered that they use en-bloc whenever possible, and just 12% never used this technique. But over the last 5 years, we see, if we look at the PubMed, we see that this technique is becoming more and more widespread all over the world. So what are the advantages of en-bloc? And we will discuss them in detail during this presentation. So first of all, we have better pathology. We have less complications, important. No limits in energy, location, and size during en-bloc resection. And the most important thing is oncological outcomes, and more recent prospective randomized trials show the advantages of en-bloc over standard transurethral resection. So regarding beta pathology, there was very important and very interesting study published in World Journal of Urology. There was a collaborate study of EU section of urotechnology and section of uropathology of over 68 pathologists from 23 countries. And the majority of them mentioned that ERBT is more preferable for the pathology analysis quicker and more better staging. So most of the pathologists mentioned that they prefer to analyze material after en-bloc than after standard transurethral resection. So most of the studies mentioned that if we talk about the diffuser detection rate, so all the studies mentioned that with en-bloc resection, we got better diffuser detection rate. And currently it's very, very important. Another issue is regarding complications, so bleeding, obturative nerve reflex, less with en-bloc resection. When we do en-bloc with lasers, we absolutely exclude such complication as obturative nerve reflex. It's very important. So different energy sources are available for en-bloc. So we can do it with electrocautery, mono and bipolar, and with different lasers, with holmium, low power, high power, thulium, YAG, continuous pulse, and thulium fiber laser. So, and the jury is out on this one. So some surgeons, some esteemed surgeons, such my good friends as Thomas Herman and Lucas Lusardi, they sure that energy source absolutely does not matter for en-bloc resection. And like with endoscopic enucleation of the prostate, energy source is secondary. However, is it really so? We should remember that electrocautery sometimes may cause obturative nerve reflex, and as a result, with the serious complications, a real nightmare for urologists. Moreover, according to study published by Donna Hansel in European Urology, electrocautery may damage the sample, and no diffuser will be seen on pathology. So, and finally, once again, if we look at the PubMed, we will see that, of course, more and more specialists, clinicians all over the world interested in using lasers for en-bloc resection. So the classical procedure, we do it with a laser, 5 to 10 millimeter margin around the tumor, and slowly we know that the bladder wall is very thin, it's just 4 millimeters. So our goal is to go deep under the muscle layer and resect the tumor. So, and with lasers, we can clearly see the muscle. We're absolutely safe, no bleeding, and resect the tumor very delicately, precisely, and follow the main oncological principles. So, and when the tumor is less than 3 centimeters, we can easily remove it through the endoscope. However, if the tumor is larger than 3 centimeters, what should we do? And some time ago, also my good friend Jeremy Teo from Hong Kong, China University of Hong Kong, he published a collaborate trial. It was a consensus, a Delphi survey regarding en-bloc. And the decision was, the final decision was of this consensus of this meeting was that en-bloc is absolutely feasible for patients with tumor larger than 3 centimeters. So how usually surgeons remove this tumor? So there are different strategies. Someone use Alex evacuator, someone use laparoscopic grasp, endobag. Some surgeons ablate the tumor and then the exophytic part, and then perform en-bloc of the base and remove it through the endoscope. However, in our experience, we perform morcellation, and contrary to what it seems, we do not violate the principles of en-bloc. So at first, when we start doing that, we perform two-step approach. So with large tumors, at first we do superficial resection and resect the exophytic part of the tumor. Here it is. Then we perform morcellation and morcellate this tumor like we morcellate BPH during endoscopic enucleation of the prostate after enucleation. So this is material, and this material we at first send to pathologists and have a very good grading. And next step, we perform en-bloc resection up to the deep muscle layer of this base of the tumor. And this base we easily remove for the endoscope and send it separately to pathologists. And with this material, we have this is how it looks like. And with this material, we have very good staging. But afterwards, we decided to do en-bloc of the whole tumor. So do not do two-step approach and perform en-bloc immediately for the same tumor. So this is an example of the big tumor, about 4.5 centimeters. So this is the video. And what we do, so we keep the margin as we usually do during en-bloc resection and go up to the deep muscle layer and slowly resect the tumor. So usually, and we can clearly see the muscle here. We can clearly see the base of the tumor and separate all the tumor. So we, at the same time, we calculate all the bleeders. So you can see that there is no serious bleeding during this procedure. You can clearly see the muscle. You can clearly see the layer. So it may seem that the procedure is rather simple and very easy, but however, it of course the surgeon should get some experience with doing this procedure, not to go superficial and not at the same time not to go too deep to perforate the bladder. So it's very important to find the layer and follow this layer and resect the tumor. So this is how it looks like. So we make a circle incision around the tumor, and then we go from both sides, we go to the middle and resect the tumor. Then we morcellated the whole piece, the whole material, we morcellated. So usually as the tumor is rather soft in contrast to BPH, so the morcellation goes very, very quickly. This is final coagulation of the wound with a laser, all the procedure we do with a laser. This is the final view, how it looks like. And we send the material from the morcellator, we send to pathologists. And our pathologists more than happy. This is how the tumor looks like. And our pathologists more than happy. So they give us full reply, full response regarding the material. So We know what is the grade of the tumor after analyzing material from the morcellator. The most important part, we can even say it's T1 or TA tumor, and of course, invasion into the muscle. So, and analyzing the material, our pathologist can give us clear answer regarding that. So, is the muscle, is there is invasion to the muscle or not? This is another case. So this is a tumor more than 8 centimeters. It was a rather patient or 80 years old with a bleeding from this tumor, and we decided also it was like a emergency surgery, so we decided to do en-bloc in this case, and the surgery took about 3 hours, so it was not an easy case, but finally we did it. So we removed all the tumor, and this is how it looks like. So we found there was a wide base, and we found the base and followed the muscle layer and remove the tumor, so you can clearly see the layer. And this is the final view of the tumor, how it of the base of the tumor, how it looks like. Then we do morcellation. Morcellation also took some time, and especially in this case. And finally, this is how the material, it was about 100 grams of morcellated tissue. So it's really was very unusual case. And this is a cystoscopy 3 months after the procedure. This is urethral orifice, and this is how the wound, how the bladder looks like. Of course, the patient is a very high risk, and we will monitor the patient. However, the outcome is rather optimistic. So we presented this technique in during EAU meeting and AAA meeting, and it was awarded as one of the best surgery during this meeting. Now we see that this strategy is becoming more and more widespread, and our colleagues from Brazil published their study in Urology Gold Journal, and they performed en-bloc with morcellation for 8 cases, not a lot, but all the cases were successful. They got the muscle in all cases and removed the tumors. And now our study in on en-bloc for large tumors is also accepted in Minerva Urology and Nephrology Journal, and it will be published soon. And we are looking forward to seeing it online in the nearest future. So another advantage of lasers doing en-bloc is when the tumor is located close to the orifice. So lasers allow us to keep this distance and follow doing en-bloc without damage of urethral orifice. However, if the orifice is involved into the tumor, in such cases we do en-bloc of the whole area. You can clearly see there is no burning. When you use the right settings, there is no burning of the tissue. You can clearly see it. And finally, we put a stent to prevent urethral stenosis for 2 weeks. So this is how the tumor looks like, finally. So, and regarding location, there is no contraindication of any location for en-bloc resection. For example, here, the tumor located on anterior wall. So during such cases, I just always ask the assistant to push the anterior abdominal wall, and it comes close to the endoscope, so I can easily remove it. So even this location is not a contraindication for en-bloc resection. So our study was published, comparison of en-bloc with standard resection was published in Bladder Cancer Journal. It's the main journal of American Association of focuses on bladder cancer. And the study showed that en-bloc provides better detrusor detection rate and better relapse-free rate. And even currently, we have 29 clinical trials on comparison en-bloc with standard resection. We even have 5 meta-analyses on this topic. Some studies show the advantages of en-bloc. Some studies show that it's comparable with transvaginal resection. However, what is important to know that we do standard resection over the last 100 years and en-bloc only over the last 15 years. And of course, en-bloc is becoming more and widespread, and more specialists understand the concept of this procedure and do it do it more precisely. So, and of course, as we get more data of en-bloc over, and especially last data over the last 2 years, 3 years, it showed the advantages of en-bloc over the standard transurethral resection. The last but not the least, and the question which is always frequently asked, so can we introduce chemotherapy after en-bloc resection? And of course, the answer is yes. And there is no contraindication for mitomycin right after the procedure. Moreover, it is indication because we clearly see that there is no perforation, we clearly see the muscle layer, we clearly see the wound, and we can say that there is no perforation when we can easily perform mitomycin right after procedure. And the majority of studies show that there is, once again, there is no contraindication for that. So this brings me to the end of my presentation. I would like to sum up that, first of all, en-bloc is given a perfect material for pathologists, and we know how important is it currently. It's absolutely safe technique, and all the studies show that its advantages over standard resection in terms of complications. You also can see that there is no limits in size, and now morcellation open absolutely new horizons of en-bloc resection, and we see that the material after en-bloc without any electro damage, without any thermal damage, so it's high quality material, and our pathologists are happy to analyze this material, and of course it shows new horizons for en-bloc resection. There is also no contraindications in terms of location for en-bloc. Well, regarding energy, which energy source is preferable, the jury is still out on this one. And for example, my colleagues, Mario Babchuk, Professor Lucas Lusardi from Salzburg, they perform electro en-bloc perfectly, and they control everything during the procedures. At the same time, my personal experience, I prefer using lasers because it's easier for me to control due to minimal penetration depth of lasers. It's easier for me to control the penetration depth, so to get to the muscle and not to perforate the bladder. However, once again, the jury is out on this one, which energy source is preferable. And of course, we are now doing more and more randomized trials on en-bloc, and specialists all over the world, we see that they're interested in that, enjoying these trials, and we are looking forward to the nearest data, which will come from all over the world, from all the experts, and will shed more light on this surgical direction. Thank you very much, Chandra. Thank you, dear colleagues, for your attention.
Thank you very much.
Thank you very much.
I will ask some questions because I also practice and I believe in it. So my first question is, if you do morcellation, not only the superficial part of the bladder, but the deeper part, which you are interested, will pathologists be able to give information on the detrusor muscle in the morcellated tissue? You said
Sure.
yes. How do they take the bunch of the tissue, distribute? Can I know a little detail how they identify the muscle and then the tissue, how much deep it is going?
So it's a good question. So that's why I showed the procedure and showed the pathological review. So we have a rather big experience of morcellating such tumors. And I did these procedures in Moscow. I do these procedures in Vienna and in Tel Aviv. And the pathologists in all countries, they are more than satisfied. And I think that the important issue will be our paper, which are preparing now and will be published soon, on pathological aspects of morcellated tissue. So the concept, Chandra, that pathologists give us full reply regarding invasion into the muscle or not. So analyzing this material, like pathologists analyze BPH tissue after endoscopic enucleation of the prostate, and they can tell us regarding if there are any cancers, cancer cells, what type of cancer cells. So it's the same with the bladder tumor. So the only one disadvantage that using morcellation, we cannot give information regarding lateral margin as we can get when we remove the tumor after, if the tumor is less than 3 centimeters and we remove it for the endoscope. So we cannot give information regarding lateral margin. However, the most important information regarding invasion into the muscle, moreover, invasion into lamina propria, the pathologist can clearly give us analyzing this material. And that's why this is I think the main message of this presentation that we would like to address to our colleagues, that it is important. And even now we see that this technique, this strategy is becoming more and more widespread. And even our colleagues, the study that I've showed from our colleagues from Brazil in Urology Gold Journal, they also did it and they got the same success, got the muscle, got the very high pathology. And of course, it will be interesting for us to analyze the pathologists' review from all over the world regarding this, their opinion on this material. But what we have now and what we see now, that our pathologists are really happy analyzing.
Yeah. So my second question is there any concept of radical en-bloc resection of bladder tumor in very old, frail patient, where you are, if the patient is not willing for radical cystectomy, can you remove the large tumor completely, going to the extent of perforating the bladder and remove the entire in toto?
Well, Chandra, it's a very good question. Now we know that trimodal therapy is becoming also more and more widespread. And the last meta-analysis which was published in British Journal of Urology, so the advantages and absolutely comparable outcomes of trimodal therapy, comparable to radical cystectomy. And of course, it will become more and more widespread. So, and of course, I think that en-bloc can play an important role in this treatment. So with using en-bloc, we got the muscle, we go as deep as possible, and afterwards, if we send these patients for radiation therapy, for systematic chemotherapy, so we get very, very good oncological outcomes.
Okay. If the urethra is very narrow, have you ever used the laser en-bloc resection of bladder tumor using miniaturized nephroscope, something like that? Have you ever tried?
Chandra, could you please clarify the question?
Yeah.
I didn't catch
if
it.
If the urethra is narrow, stricture,
okay,
in a male patient, have you tried with a small cystoscope, same en-bloc?
Well, we know that now the era when endoscopes are becoming smaller and smaller.
Yeah.
Personally, so usually I use 26 endoscopes. So, and I feel happy with this. At the same time, when I have some problem with the patient's urethra, I have my own 24 French endoscope and I use it. Now we know that we have 22 and even 18.5 irrigation resectoscope. However, for en-bloc, I prefer to use the larger one because usually when we resect the tumor, we remove it through the endoscope, and it's better for me to have the larger one. However, if there is some problem with the urethra and I see any problem, so I use my 24 and it's in 100% it helps me. So, yeah. However, it's more difficult to remove the tumor, especially when it's larger one through the smaller endoscope. And you should remember about it.
Yeah. Last couple of questions.
Sure.
With the same principle, solitary kidney intrarenal tumors, can you safely do submucosal resection of superficial tumors with laser and can save the kidney? And with can it be the future of management of very early stage transitional cell carcinoma of PCS kidney? Transitional cell carcinoma, can we apply in the kidney en-bloc resection of bladder tumor?
Well, Chandra, could you please also clarify your question? So we talk about
if
using
you have
laser.
a solitary kidney,
Okay.
transitional cell carcinoma of the renal pelvis and papillae, can we apply the same principle of en-bloc resection of bladder tumor, en-bloc resection of pelvis or renal tumors?
So, Chandra, if I understand you correctly, we use lasers to ablate the tumors, to ablate the UTUC. We talk about this one.
Yes, yes.
So now we see, we use lasers a lot, and now especially new lasers we use to ablate the tumors. We also use now lasers for kidney tumor RCC ablation.
UTCC.
If we talk about upper urinary tract tumors, so we see that now more and more data and more data coming from also from Israel, from all over the world. Specialists do ablate the tumors and got very good outcomes. So, and different lasers used for that. Usually, and well, the lasers with continuous wave mode are more preferable for this because they ablate the tumor, not rupture it when they ablate it. So, and we see that now it's becoming more and more widespread. So it's a good option, and I'm sure that it's the future is bright for that 100%.
Last question. Superficial bladder tumors. En-bloc resection takes time, whereas TURBT is quick. In 1 minute, you can take it off. Do you think in superficial tumors, also en-bloc resection is useful?
Well, it's it's a little bit provocative question, because if we talk about regarding the time that in experienced hands, for me, for example, to do en-bloc and to do transurethral standard resection, the time will be the same. So regarding superficial tumor, if it is a small tumor, absolutely superficial, so we can take it with a loop, so it's absolutely not a problem. But if it will be tumor more than 5 millimeters, so I will prefer to do it with the en-bloc. So regarding, once again, Chandra, regarding the time, it's a stereotype, and if the surgeons get more experience with en-bloc, the time will be absolutely the same, and all the other advantages also come with en-bloc.
Thank you very much. Very nice, very academic presentation. A lot of papers you are doing on that. All the best for your research, and we love to listen from you. This is not only India, and 10,000 urologists are in the group. They will listen tomorrow, day after tomorrow, but the link will be same. It's a YouTube link. So I am very thankful to you. Thank you very much.
Thank you very much, Chandra. Thank you for your invitation, and it's also always my pleasure to share some thoughts with you. Thank you.
Thank you.
All the best.